go to extra school for this. So if a primary is doing better than that, well, I suppose that says something on that pain doctor. But the idea that people get so many epidural steroid injections in such a short period of time is outrageous, quite frankly. I'm not a big fan of the epidural steroid injection. Probably to date, it's still the most commonly performed pain management procedure done in the United States, followed by medial branch nerve blocks, rhizotomies, joint injections, things of that nature. So definitely the epidural steroid injection has been around a long time, and it's very commonly done. Many people don't know that it's actually not FDA approved. It's considered to be an off-label use for that type of treatment, to put steroid into the epidural space. We talk a lot about the FDA and FDA approval, and that's sort of an interesting fact that even though that's still the case, we do it so often. What is a normal amount of steroid injections that you should get within a year? I think historically, we've done things a lot different than we do now. There used to be a series of 3. And if any of you are watching this and you had this done to yourself, let me know in the comment section below. But there used to be a series of 3 epidural steroid injections. So you go into your doctor, you say, oh, I got some sciatica, it's failed conservative treatment. You may be recommended a series of epidural steroid injections. So what that looks like is you go in one day, you get the first injection, you come back a week or 2 later, and then another week or 2 to get it, let's say 3 injections in a row. The idea being that you can maximize your outcome. Well, I'm not sure that was really ever the case. Certainly, I don't think there was much evidence behind it at the time. Probably done more for billing purposes, to be fair. And perhaps even a lot of older doctors might still practice that way. I mean, just in the last couple of years, I've still seen that kind of pop up every now and then. Not too often anymore. But that's what would happen. You get a series of 3, and maybe it worked, maybe it didn't. It fell out of favor because what happens, well, it's always money, right? So people started looking at it and they're like, well, what's the evidence for this? Maybe we need to actually do some research behind it. But the idea is, at least the consensus became, that if you have good results with the first injection, why do you need to repeat a second one? If you didn't have good results with the first one, again, why bang your head against the wall and hope it works better this time, right? Now, there are situations where you might repeat it, let's say in a relatively short period of time. And this is how I practice. If you get a partial relief, let's say maybe even 50%, and it carries out, let's say 2-3 weeks, but we're still not quite where we want to be, then we would repeat it. But we would go at a different location. See, the idea is that maybe we need to put more water on the fire, but this particular room that's on fire has already been put out, so we need to go to a different room. So we would adjust the trajectory or the approach of the needle, maybe a different level, maybe one side or the other, to try to get more of an effect. But that's the only time. There'd be a partial effect, and we try to improve the outcome. But again, if you're doing really well after the first one, there's no point in moving on with the series. So that practice has sort of fallen out of favor. But again, what keeps coming up are patients saying, I've had so many injections in a year. I mean, 6, 7, 8 injections in a year. Jamie Bates says she had 7 in 1 year and had problems with it. I had other patients tell me they've had 10, even up to 10 epidural steroid injections in a year. Even now, this is what's happening. So what's going on there? I think, as a patient, you're sort of at a disadvantage because, well, I mean, you didn't spend a decade studying the science, the practice, and you're reliant on a professional telling you that, oh, well, just one more injection and I think we're going to get it. And unfortunately for a pain patient, a lot of pain patients are willing to almost do anything it takes to get out of pain. I think Keith mentioned that the other day. If the doctor tells me to jump on my left foot, and if that's going to cure my pain, I'll be jumping on my left foot, But is that really a good way to approach it, with so many injections in a year? Today, I'm going to give you a little bit of insight into what perhaps the standard of care is, or should be, or is recognized as. when it comes to epidural steroid injections. And there's a reason for all this. Okay, so the following are societies that have come together or contributed in some way to what the standard of care for epidural steroid injections is as it stands today. Okay, and the standard of care has been adopted by Medicare and virtually every commercial insurance that I know of. Okay, there's always little nuances, but here's what it boils down to. So here are the societies that have contributed to that: the Spine Intervention Society, the American Academy of Pain Medicine, the American Academy of Physical Medicine and Rehabilitation, the American Society of Anesthesiologists, the American Society of Regional Anesthesia and Pain Medicine, North American Neuromodulation Society, North American Spine Society, the Pain Society of the Carolinas, the Society of Interventional Radiology, Tennessee Pain Society, Florida Society of Interventional Pain Physicians, the American Society of Interventional Pain Physicians, and the Society of Interventional Pain Management Surgery Centers, just to name a few. Okay. Of course, these societies represent thousands of physicians and literature that has been peer-reviewed and have come together to agree on what the standard of care should be for epidural steroid injections. If anybody watching right now, how many, by the way, I just read that off that whole list. I felt like I was introducing the winners at the Oscars. Thank you, everybody, for this beautiful award. If you are watching in the comments, go ahead and drop me a number. How many epidural steroid injections do you think a patient should get within a 12-month period? What do you think the standard of care should be as adopted by the current literature review and professional societies?
I'm going to go on a limb and say at least 4, maybe 1 a quarter. Would that be about fair?
Okay, yeah. Somebody's been doing their homework. I guess you do work in a pain clinic, so.
Am I close, really?
No, yeah. No, so the answer's 4.
Oh, wow.
Yeah.
That's a complete guess, really.
No, so the idea is that we're limiting epidural steroid injections to a maximum of 4 injections per spinal region. So neck, you can have 4 in a year. Back, you can have 4 in a year over a rolling 12-month period. Okay? And so that totally eliminates the idea of doing 3 in a series. In fact, there's specific recommendations against doing 3 in a series at this point for some of those reasons I outlined earlier. So 4 in a year. So why are we doing 4 in a year? What's the purpose behind that? I mean, yes, it's cost savings, but let's be honest, they're not paying anything for epidural steroid injections anymore anyway. There's actually significant health consequences. I mean, like I said, epidural steroid injections are the most commonly performed. They're very safe. I mean, the idea of putting a needle into somebody's neck or spine, yes, that sounds horrible. And if you're not trained to do it appropriately, yes, bad things can happen. Fortunately, the catastrophic outcomes such as might be defined as bleeding, infection, or even, infection to such a degree it causes nerve injury or spinal cord injury, right, due to abscess formation and things of that nature. Direct spinal cord injury, right, those cases do exist where the needle does go too far, right, and into the spinal cord. Fortunately, all of those really horrible things are extremely rare, like a fraction of a percent rare, okay? And knock on wood, I have never seen it. I've maybe heard of one case in all of the exposure I get to talking with other physicians and the community, but that's the good news. Those things are rare. I know we talk about it, but don't freak out about it. Okay, Kevin, you had a question?
I do have a question. So you said 4 per spinal region. That would be at least maybe 4 in the neck, 4 in the upper back, 4 in the lower back. So like what, 12 a year you could get?
Theoretically, but most people don't have indications for an epidural steroid injection in their neck, in their mid-back, and in their low back. I'm not saying people don't have pain throughout their whole spine, but usually that's an exclusion to proceeding with an epidural steroid injection. A good indication for an epidural steroid injection is really a focal area of pain that is causing nerve-type pain, radiation into an extremity, that type of thing.
Right.
So
the
odds of that happening in all 3, right? So the spirit of the law really is The spirit of the law is no more than 4 a year.
Gotcha.
Yeah. So there's another question. Yeah, Keith put in here, is that an association rule or a state or insurance rule? Yeah, so at the end of the day, this isn't really a rule. I mean, it may dictate what you get paid for. But when I read all these societies, they have come together individually and then within a conglomerate as they work with Medicare and other insurers to define what insurers should pay for. And that is based off of the research, the literature, what is effective, what is not effective, what is safe, what is not safe. So even though we say, oh, well, insurance sort of dictates it, in most cases, that is based, their recommendations or their protocols are based off of the literature, are based off of what physicians are able to demonstrate as being effective and safe. So hopefully that answers your question. Yes, it is an insurance thing, but that's sort of the outcome of all of the work that was done ahead of time. Okay. And there's always exceptions too. Like, that's the beautiful thing of being a physician, is that as long as you can come up with a good argument for why you need to do what you need to do, then you should be able to do it, right? You're going to always be subject to peer review. You're always going to be subject to, potential lawsuits and investigations and things of that nature. So you have to be able to defend yourself. What is the experience that you have to demonstrate this particular treatment? What does the research show? What does the literature show? What are your peers doing? What is the standard of practice? What does the Texas Medical Board have to say about it? So you do have to be able to defend yourself as a practicing physician, and I think we all agree that's a good thing. But these are not laws. You can't have more than 4 a year. No, that's not true. But that is the recommendation that all of these people have come up with. And again, there's reasons why. We talked about the catastrophic outcomes, but there are less catastrophic outcomes, we call them maybe side effects, that occur on a much more regular basis. And that is due to the frequent exposure to steroids, right? We know steroids are not good for you. And the risk of these outcomes increases with the dose frequency. So take spinal fractures, for example. Osteoporosis, weak bones. You can get compression fractures in your spine. You might have heard of this. Additionally, you may fall on the sidewalk and crack your hip. You're much more likely to crack your hip if you have weak bones. What causes weak bones? Lots of things, but steroids is a big cause of that. So we know that with each subsequent injection, epidural steroid injection, where we're putting that steroid in the spine, that directly affects the strength of your vertebral bodies, the bones in your spine. With each subsequent steroid injection, we have literature to show that you have a 20 to 30% increased risk of spinal fracture. And you can develop these spinal fractures if you have weak bones, not by getting into a big car accident. I mean, yes, that's possible, but it can be just as simple as a sneeze. I've seen that happen. A poor little old lady, she was sneezing at her kitchen table, and she developed acute, severe pain in her lumbar spine. Went into the emergency room, x-ray showed a fracture of her vertebral body. Her bones were very weak. That's all it can take. And we know that with each subsequent epidural steroid injection, there is a 20 to 30% increased risk above baseline for someone to develop a spinal fracture. Now add that up over several injections. I mean, that definitely is a concern. Adrenal suppression, right? We talk about POTS disease and adrenal fatigue and chronic fatigue syndrome and poor stress tolerance, low blood pressure, dizziness, these types of things, right? This is already very common in the chronic pain world. And every time you get a steroid exposure, even if it's in the spine, there's a 2 to 3 week period where your adrenal system is suppressed. And imagine now if you have multiple every year, you're looking at, let's say you have 4 injections in a year. 4 times 3 is 12 weeks. That's 3 months out of the year now where your adrenal system is taken out of the picture for 25% of your life that year, right? With just 4 injections. So it definitely adds up. And by the way, this is not also taking into account other steroid exposure. If you had a steroid dose pack, if you had a knee injection, a shoulder injection, right? These are all additive. And so that's something to definitely something to consider. Weight gain, fluid retention. Of course, if you have diabetes, hyperglycemia can be exacerbated. And we also know that with each subsequent steroid injection, the benefit generally is reduced. We have something called diminishing returns, which is why myself and many other practicing physicians, we love steroid injections for acute pain. But for chronic pain, it's really not so great. It's often used as a patch. So it's frustrating when there are protocols in place where you have insurance companies, I would say, that are not acting in accordance with what physicians would argue for. Now, in this case, this is what physicians are arguing for. No more than 4 a year, generally speaking, per spinal session. This is what physicians are arguing for. But there are things that insurance companies like to do that may be outside of what should be happening, such as, well, you need to maximize conservative care before we pay for something bigger, whether it's a surgery, whether it's a stimulator, whether it's a minimally invasive fusion or some other type of bigger treatment. We have to do a steroid injection first. A lot of these programs these protocols require that. But the problem is with chronic pain is that it's like, well, you've already been dealing with this for so long. Okay, we do a steroid injection. Okay, we bought you 3 months worth of pain relief, but now what? We need to repeat the steroid injection. Okay, and then maybe we get you 2 months of pain relief, and then we do it again, and next thing you know, we've done 4 steroid injections in a year, and even with that, we've suppressed your adrenal system for 3 months out of the year, and hopefully you've not developed any other complications. But then we're basically back at the same place we were when we started, except we've lost a year. Oh, but now we'll do something different. How many times I wish we could just go to something that is actually going to solve the problem from the beginning. I mean, it makes sense. You don't want to just jump to the most invasive thing. I'm not arguing for that, but I also think that we should be doing something that's going to work. And if we already know that steroid injections have complications and they're going to burn out anyway, I mean, I don't know. It seems like we're wasting our time. If you agree, let me know. If you disagree, also let me know. I mean, hey, I'm here to learn something too, but that's sort of my perspective on that. Acute pain, yeah, we'll do epidural steroid injections all day long because there's a good chance all you need is one. With chronic pain, I don't think that's the same story. So yes, as it relates to epidural steroid injections, it is generally not considered medically reasonable or necessary for treatment with epidural steroid injections to extend beyond 12 months. So even if we are using it for purposes of acute pain or chronic pain, the recommendation is that we don't continue to do that beyond 12 months. Something else needs to happen. How many of you have gotten maintained with steroid injections on a regular basis for more than a year? Well, it's not recommended. So I want to go back to what Jamie Bates was saying because there's more to unpack here. I appreciate you hanging out with us today. So her primary care doctor took over her pain management. Good for that primary care doctor. Until 2023 in California, the pharmacy I had been with for 13 years said my prescription had to come from pain management doctor, not the primary care, due to the DEA, which terrified me, and I explained my trauma to my new pain management doctor. So right there, we're going to pivot a little bit. What is the role of the DEA in all of this? Because there's so many layers of authority as it relates to how you can just get your hands on some pain medicine, right? The way I understand the DEA is they're essentially a criminal enforcement or investigatory body. So they're basically here. Yes, I'm registered with the DEA, and I have to be registered with the DEA. Anybody that writes controlled medications has to be registered with the DEA in order to do so. And that's because the DEA controls and tracks and monitors and distributes and all these things, all of the controlled substances in our country. So if they're going to be people in the country that are distributing it, they want to know who that is. And so we have to be registered with the DEA. But the DEA is not there to micromanage your practice. They're not there to tell you, well, you can't write opioids unless you do an injection first. That's not the DEA's role. The DEA's role is to ensure that I'm not an extreme outlier in prescribing opioids, right? If everybody's writing 100 scripts a week and I'm writing 10,000 scripts a week and I don't have documentation to support that, then I'm going to be investigated, right? They want to make sure I'm not a pill mill. They want to make sure I'm not diverting the medication or using the medication in some illegal way. But they're not there to make sure that my patient had an injection first or they're doing physical therapy in order to qualify them for opioid therapy. That's not the DEA's role. But we use the DEA. I mean, I don't, but, well, sometimes. But the community, the physician community, the hospitals and the pharmacies and healthcare providers use the DEA as it's almost a scare tactic, right? It's like saying, well, the DEA won't let me do this. Well, the DEA is going to shut me down and all these things. Not unless they're doing something that is going to warrant some investigation or with criminal intent, right? Or possible criminal activity, that type of thing. But it's not a crime to write an opioid for a patient in pain that is for a legitimate purpose. And that's all that has to be documented there. But that being said, the state, however, and I'm in Texas, so for me it's the Texas Medical Board, does outline certain expectations that should be followed when it comes to the prescription of opioid therapy, right? And a lot of that does require us to follow what they determine to be the standard of care, which is maximizing non-opioid treatments before introducing opioid treatments into the treatment program. And I think that makes sense. I mean, I don't know that anybody would argue with that. Let me take that back. Yes, there are people that would argue with that, but from my perspective, that makes sense. Nobody wants to get hooked on drugs if we don't have to. If there is a non-opioid way to treat pain, I mean, I would argue that we should all pursue that, right? Be free of the healthcare system by not getting ourselves potentially addicted to something. So, but that's my point. That's the difference between the DEA and the state. Okay. Now, the regulations are going to vary by state to state. But as far as I know, as long as you have a DEA license to prescribe a controlled substance, there's nothing that's stopping you or stopping a pharmacy from filling that. For example, you don't have to be a pain management physician for a pharmacy to fill your medication. In this case, it looks like the blame was put on the DEA. That's not how I would interpret this. I would suggest that it's specifically that pharmacy, and it's probably a pharmacy corporate rule or protocol that they're following, because again, there's only 2,500 pain physicians in the country, and there's plenty more that are getting prescriptions. Most opioid therapy is actually prescribed by primary care. In a lot of cases, and I kind of went back on that earlier. As a pain physician, I have a certain set of skills that extends beyond the writing of a prescription. And so for me to be able to maximize my skills for the community at large, I shouldn't be the one that's writing every prescription. I can get somebody stabilized and set onto a path and then hand back to a primary care to continue that treatment protocol for that patient. But then if they need something more invasive, or, the medication is, getting out of hand, then that's where I would step back in. But no, it's standard of care for primary to be able to write opioid therapy, especially if someone's been stable on it for 13 years, like Jamie Bates said. So that's definitely a pharmacy issue. And, I love the pharmacists. I love working with pharmacists, and most of them, but, definitely some of them are, or can be a little bit, like turkeys to work with. So, it is what it is. Sounds like Jamie Bates got a new pain management doctor, and he did not push an epidural steroid injection for a year. Fantastic. Sounds like he was able to get your medical records. He reviewed your medical records. He said, I don't need to repeat this, which I know happens a lot, regardless of whether you get medical records or not. You can have all the records in the world that say, hey, for the last 2 years, I've had 20 of these darn things. Anything else you got? And, the doctor will still put you through the protocol of, well, I wasn't the one to do your injection. And you as a patient feel so obligated to follow the plan of care because you want to be compliant. But I'm telling you, that's not the standard of care. That's the whole point of getting your records, so we don't keep hitting our heads against the wall. That's not good medicine. In this case, in 2024, so a year after Jamie Bates found the new doctor, the nurse she was seeing, maybe a nurse practitioner she's referring to, gave her the ultimatum: get injected with lidocaine or force taper. Ooh, boy. And the reason given was to get the DEA off the doctor's back. Yeah. So again, the DEA, I'm sure, had nothing to do with this discussion, unless that physician was already under investigation. But again, that should not have anything to do with this particular treatment, because again, the DEA does not weigh in on individual medical decisions. They don't micromanage that. They get interested when there's large scale criminal activity or small scale criminal activity, but you pretty much have to be large scale, I think, to get investigated. But I don't know. That's just my opinion. I'm sure they are watching everything that we're doing, but that has nothing to do in this particular case. Get injected with lidocaine. So again, I don't know if you meant that they're going to be getting injected with lidocaine and steroid, or maybe she's giving you, something in return. Well, we just have to inject you with lidocaine. We have to make it look like we're doing something other than just writing opioids. Well, if you're just doing something knowing that it's not going to work, but it makes the chart look good, and we're talking about actually injecting you with a needle, that's a little term I like to call malpractice. Okay. Absolutely not. Don't do that. Don't fall into that trap. There is not a scenario I can think of where a patient has to do a procedure, meaning an injection, a stimulator, a fusion, or anything like that, or else face the consequences of a forced taper. Now, there may be scenarios where, well, you have to do something else, right? Because again, at least how it is in Texas, we can't just write opioids. We need to be doing something else, some non-opioid treatment. And by the way, that's for everybody's well-being. That's not a bad thing. But I think where the abuse may come in is when a physician says, well, I can only offer you an injection and you have to do the injection. I can only offer you a stimulator and you have to do the stimulator. No, I don't like that. That makes me feel uncomfortable. But the truth is, a lot of physicians are not really comfortable with alternative treatments. They're not maybe so competent in the literature behind other treatments, or being able to feel confident in recommending an alternative treatment. And that's why they always, sort of backslide into what they're used to doing, what they're trained to do. So the impetus will be increased on a patient to say, well, hey doc, I really looked into this, acupuncturist. I really like to give that a try. Great, let's do it. That checks all the boxes. That gives you something that actually has a good chance of working. That gives the doctor something to document when they are audited, to show that we're doing something other than opioid therapy, right? And by the way, that's exactly what they asked me, straight up. 20 charts. The state was in my business, but I mean, they told me they'd be in my business, so I'm not getting on to them for that. But that's what they do. They look at 20 charts. They go through every chart. They say, is this patient doing physical therapy? Is this patient doing injections? Are they doing literally anything other than just writing opioids? And if the answer is yes, we move on. If the answer is no, the follow-up, why not? Where's the documentation? Why are you pursuing this patient's plan of care in this way? So you definitely have to be able to defend yourself as a physician. And like I said, a lot of pain doctors are not comfortable with things they're not trained with. So hopefully you all can individually educate yourself, but we can continue that conversation here in this forum. What are other treatments that you can arm yourselves with that have a good chance of working, are literature backed, because that's what it's going to take to get your physician on board with it. You can't just say, well, I'm doing cartwheels and that stretches my back. Your doctor's not going to accept that as alternative treatment. You have to have some evidence-based treatment. That's what we like to. That's the world we like to stay in. Evidence-based treatment that is not an injection, that can help your pain, but also keep you compliant with everything else. So, this is just bad medicine at Jamie Bates. I'm sorry you experienced that. You ended up being compliant anyway, and unfortunately suffered an allergic reaction to that injection. And now they are accepting PT as an adjunct instead of injections. Yeah, they should have been accepting PT as an adjunct instead of injections to begin with. Unfortunately, they had to injure you first. I have been harmed by doctors so much that I have lost trust in the system. Yeah. No, I totally get that at Jamie Bates, and that's why I try to stay as independent as possible. I see what other physicians go through. I see what other patients go through. Definitely the healthcare system in this country is broken. Definitely it needs an overhaul. Physicians need to be able to physize, if that's a word. Doctors need to be able to doctor, and I think when you get too many regulatory bodies involved, too many cooks in the kitchen, patients get hurt. And that's what we've seen, and that's what we've been talking about, and we want to continue to build that trust with you. We want to continue to have that discussion. What's a better way forward? This has been my Friday afternoon check-in. Please don't get more than 4 steroid injections in a year. That is not medical advice, but that is what the standard of care happens to be, as supported by multiple associations, professional associations, and all the way to the top, because definitely bad things can happen. So let's get back into the chat. How is everybody today? Oh boy, yes. Hello, everybody. Palliative has had the most creative ideas and response. Yes, Kate, that is actually very true. I love palliative care, by the way. I think palliative care gets confused a lot with hospice, and hospice tends to leave a bad taste in everybody's mouth. But palliative care is fantastic, especially for somebody that really is in dire straits, that maybe traditional pain management doesn't have the answers for. Palliative care trains specifically on a multitude of symptom management, whether it's pain, but also nausea and other forms of discomfort. They definitely have a lot of good options to treat a multitude of symptoms. If pain management's not doing you any good in your area, you might check out palliative care as an option as well. Yeah, that's a great point.
I got one question. So just a little while ago, while you were speaking, we had one guy comment on having been allergic to prednisone, and was just wondering if that's the same with an injection. I'm assuming the steroid injections.
Yeah, so there's definitely different types of steroids that we use. Dexamethasone, methylprednisolone, betamethasone, prednisolone. I mean, you can name a dozen probably different types of steroids, and they all work a little bit different. I mean, the end goal is the same, essentially reduce inflammation, reduce pain, that type of thing. So, but you know how the pharmacology of them all are just a little bit different. Um, but yeah, if you're allergic to one particular steroid, that I don't think that necessarily means that you're going to be allergic to another particular steroid. Although I would approach that situation with a lot of caution. But yeah, that is the same type of steroid that we use pretty much anywhere. A lot of people I think understand it as like a cortisone shot. That's sort of the layman term that people are used to saying. Oh, I got to go get my knee injected. I'm, cortisone.
I think that's what I might have had.
Yeah. And, cortisone does refer to a particular steroid, but we use it, generically to talk about all types of steroids. But yeah, you definitely can be allergic to it. Be careful about that. Let's see. What does Keith say? Can you tell the PCP? Yeah, lots refuse. Lots of PC. Yeah. Well, unfortunately, so the climate is such in our country that nobody wants to touch opioids. And I think that the wave of momentum is going against opioids with the under the table understanding that it will always be here. I think that they're trying to just, and what's unfortunately happening is they're overcorrecting for the possibility of misuse. But this is what they're teaching in medical schools: don't touch opioids. This is what they're teaching in fellowships: don't touch opioids. Many of you probably don't realize this, but my exposure to managing opioids as a routine chronic opioid therapy in fellowship was very minimal. And that's probably crazy to think about, because that's a lot of what we do.
Right. I was going to say the majority of.
Yeah. I mean, I wouldn't necessarily say majority, but it's a lot of what chunk. We do. I mean, right. When patients come to pain management, that's always part of the discussion, or, not always, but a lot of times part of the discussion. So, but to have such little formal training, and what the training was, don't touch opioids, essentially, so, I don't want to say a lot of it was self-taught. I mean, we had references. We get tested on it. We have to pass boards. So there's information you have to be responsible for. But in practice, most of that came once I graduated, And we do call it a practice. We're always learning. We're always trying to get better. But no, so I say all that to suggest, yeah, many PCPs don't feel comfortable with it because of the similar training they're getting. And you do have to do it appropriately. The regulation is very tight on it. You have to have your T's crossed and your I's dotted. So, I would say, but there are PCPs that do it, and there are PCPs that aren't afraid of it. So, that may be part of your interviewing process when you're looking for docs. Hey doc, how do you feel about this? Because I've been on it for a long time. I've been real stable on it. It's been helping me stay functional. It's been helping me move. We haven't had any problems. I can give you records. Saying things like that, I mean, assuming it's true, helps to put the physician, the primary care, at ease, and they might be more comfortable, working with you on that regard. But I mean, every doctor gets asked that pretty frequently, and it's not a very small amount of time that there's situations where that doctor legitimately doesn't want to get involved in. So, but yeah, there's definitely ways to do it. I think if you had your pain doctor work with your primary care doctor, especially, and if you're coming from a long ways away to see your specialist, you really can't afford the specialist co-pays, with your insurance, because usually those are more expensive. Getting your pain doctor to network with your primary, do a little bit of hand holding, essentially. Say, hey doc, as the pain doctor, I've been following, your patient for some time. We've tried these things. We got this patient stable. I don't see any problems with you maintaining this medicine. And if there are problems, you can give me a call. in that case, I think, your doctor may be more willing to do that. But yeah, I mean, that's part of the game that, we have to play.
I've always heard there's no such thing as a stupid question, but I feel a little like I might have some stupidity coming on with this one, but I still got to ask. Okay.
This is a safe place, Kevin.
Yeah, I hope so, because here's the thing. Whenever I hear the word steroids, I'm constantly thinking about bodybuilding, sports athletes, things of this nature. All right.
Yeah.
And I've heard the term anabolic steroids. Is that within the same category of like the prednisone and all this that we're talking about now?
Yeah, great question. Simply put, no.
Yeah.
Steroids, is a broad term that basically identifies a particular organic chemistry molecule structure. But, our body makes steroids naturally. We have adrenal glands. We have all kinds of steroids that come out naturally in our brain and everywhere else. So there's different types of steroids. Now, what we're talking about here is like a corticosteroid. It's basically used for pain and inflammation. Yeah.
Gotcha.
Great question.
Gotcha. Thanks for clearing that up.
So let's see here. Going back to the chat. Just Don. So how did you happen into pain management from your former practice with addiction? Oh, did I forget? How did you know I was in addiction before? Oh, man. People have been reading about me.
You might have mentioned it in one of your earlier.
Yeah, well, pain management and addiction, that's a great question, by the way. Pain management and addiction are really two sides of the same coin. In sort of the psychology aspects, the emotional aspects, the management aspects as well. And when I say pain management, I mean particularly pain management with long-term opioid therapy. So, and I'm not saying every pain management person is addicted to their opioids, but the understanding of how things work, again, it's sort of two sides of the same coin. So it really wasn't a big leap. I actually did not want, since we're talking about it, it's Friday. Everybody's here. Everybody's warm. Let's talk about it. So, no, actually, I did not want to go into pain management.
Really?
No.
Not for. What was the first choice?
Well, actually, what got me into medicine was pediatric cardiology.
Wow.
I know. I wanted to transplant children's hearts. Can you believe that?
Wow.
I have no idea why. Once I had kids, I realized pediatrics was not for me. Because
there's a lot of weight on that, I bet.
Oh man, I could not separate myself.
Mm-hmm.
I could not separate myself emotionally from that. It was too much. So, family started to become more of a big role in making sure I have time for them and that type of thing. So, I fell upon. Oh, Keith said I told you. Sorry, Keith. I don't remember anything these days. I'm working too much. I fell upon the world of physical medicine and rehabilitation. PM and R. A lot of people think it stands for pain management and rehabilitation, but no, it's physical medicine and rehabilitation. And this is where we focus on, physical rehabilitation, physical therapy, the musculoskeletal system, the peripheral nervous system, and it was very functional to me. It made sense. It was a great way, I think, to impact a lot of people because the specialty sort of melds into every other specialty. But it was really where the rubber hits the ground. It was physical. We're not necessarily just hypothesizing and trying, experimental medications and things of that nature and, analyzing micro changes. No, this specialty can help somebody get from being in a bedridden status to, playing outside, with their kids, So that to me seemed very fulfilling. And then pain management sort of just fell into that because so many of these patients are dealing with pain, right? The musculoskeletal system, arthritis, joint degeneration, and neuropathy, and nervous system problems, and then there's certainly a big medication component to this in order to allow people to be able to participate with therapy, right? If their pain was too bad, they couldn't even participate. So even still, once I thought about adding pain management as an additional year of training, I got resistance from my higher ups, so to speak, because pain management is a difficult world. It's a challenging world. We have challenging patients, and it's a challenging ecosystem, and that you're hyper regulated, and you have a lot of people looking over your shoulder, and if you upset the wrong person, you could be in danger, right? And so there was a lot of discouragement there, but I saw a need in just my primary rehab community that I think an extra year of training would prove to be quite useful, and it has. And the more that I've got into pain management as a practice, I was like, whoa, there's a potential to do a lot of good here.
Okay. Which
Um,
aligns right back to your to what you wanted to do in the first place, which was make a difference.
we want to make a difference, and what greater way to make a difference than to help somebody out of their pain? I know that sounds like very cliche, but and it is hard work, and there's long hours, and there's lots of paperwork, more paperwork than I ever was told there would be. So thanks for that. All you medical students out there watching this, it's way more paperwork than you think it's going to be. Okay. It's not all house and scrubs and all that fun stuff. Not by any stretch, but no, I would say, when you are able to help somebody go from a place where they're crying in pain to a place where they're crying with happiness, it does make it worth it. It really does. And no, that's not every patient. I wish it was. But there are patients that happens to, and you're like, hot dog, how can we do that again? And then the whole reason for the podcast, right? It's like, well, okay, but now I'm like limited. There's a huge need here. There's a huge need. There's hundreds of millions of people in the world. There's 100 million people in our country that are dealing with this. And, I can't see everyone. No pain doctor can see everyone. And the world is changing. Healthcare is changing. I think people are going more towards their own investigation, which you should, right? I mean, there's been a huge distrust in the healthcare community. Rightfully so. We don't have to go too far back in recent history to illustrate multiple examples of that. But I'm not going to mention it because I still like being on YouTube. But that's the thing. So we're going towards more self-education and preventative type treatments, and the younger generations, feel free to speak up, but like they're not interested in what has been traditionally done for pain management. They see their parents, their grandparents, or medicine in general. They see their family members, their older generations going through the system and hearing and watching how terrible it is, and how long people have to wait, and all the insurance problems. And then, you go to bed with 20 pill bottles next to you every night. I think people are wanting something different. They want more of a preventative approach, if at all possible. And I'm not saying this is the only way, but the culture is shifting in that way, where it used to be, well, you go to a doctor, you get a pill, you feel better. But we're realizing that the healthcare system is sort of failing us in so many ways. Like the American Heart Association, we're still dying of heart disease, #1 killer in our country. 2/3 of the country is obese. American Diabetes Association, right? Almost two thirds are pre-diabetic or diabetic, right? Like what is it that our system is really doing to help us? It's not an individual problem. It's definitely a system problem. And I think people are beginning to reject it. And my goal is to be open to that and be able to sort of be on the front lines for that transition, if you want to call it that, to get the message out, to get the health message out. What does proper pain management look like as I see it? Okay, I'm not saying I'm the only authority. No, as I see it, right? It's my opinion. I get to say that as a physician. It's my opinion. Not the only opinion, right? But to be able to reach as many people as possible, to provide that education, to help bring some clarity to the mess that is on the internet, and be able to be a place where people can find some support and some clarity and some peace in the storm. of what we're all going through. So, yeah, I mean, you got me on my ledge, so thank you for that question. But here we are, and it's Friday, and I appreciate you all so much. I've been looking forward to this all week. Been cooped up at home. By the way, I was gonna not mention this, but my back pain is finally better. I gave myself back pain this week. I did a little experiment on myself because it was all ice outside. Can't really go outside. It's too cold. I mean, it's not snow. You can't play in it, you know. No snow angels for Dr. Dustin. So I'm inside. I'm just sitting on the couch, you know, whipping stuff away on my computer. Apparently, I did that for too long, like hours a day.
Okay.
For multiple days.
It sounds like you prescribed yourself.
Whoo, man, I got some real bad back pain.
Yeah, sitting will do it. Sitting will do it.
Real bad back. I'm like, okay, all right. So I need to tell my patients to move more. But you already know that. So anyway, any other questions in the chat today? I want to make sure I hit everything before we sign off for the weekend.
I think this is more of a side note until someone else puts one in. So I'm listening to the progression that you're given, and in my mind, I'm thinking about the future of what medicine and pain management looks like, especially with robots coming on the scene and more AI. And I'm not even sure if we'll be seeing doctors much more, if we'll be seeing like an iPad with a face on it, and that will be doing the prescription, or who knows.
Yeah.
But what do you see in your view?
Oh, man. It's not pretty. You know, I mean, I'm a millennial. There's no secret about that. So we've had the opportunity to grow up in an analog world and then also a digital world. And it's becoming increasingly digital. Mm-hmm. Yeah, I think AI is going to be taking over a lot of things. Traditional physician-patient relationships, I think, will continue to go by the wayside. The healthcare system, I don't think, really wants doctors. We're too expensive. Right?
I was going to say, so you want robots?
They want robots. They want automation. They want mid-levels, nurse practitioners and physician assistants, PAs. Nothing against those guys. I work with them all the time. I mean, very bright, capable individuals, but they are less expensive than physicians.
Right.
So I kind of envision a world where medical decisions, I mean, insurance companies are already using AI. And, you know, I don't think it's any secret, but physician clinics are already using AI to combat the insurance's AI.
Nice. Yeah.
I mean,
okay.
So we have AIs already competing with each other, and we're just, you know, sitting on the sidelines watching it happen. That's where it's going. And I think, you know, more of the in-person care is going to be directed by mid-levels, and then, you know, we have insurance AI, and then, you know, the few physicians that remain will be, you know, policymakers, decision makers, more outside of patient care. I see that probably happening more and more. I mean, there's already a physician shortage, and there's articles being written about it every week. It seems like that it's just getting worse. The world for physicians is not what it once was. It's you really have to love what you do to become a physician now. You really do. And if you have a buzzsaw, let's say, or a physician that, you know, is clearly not operating in your best interest, let's say, or taking the time to have the conversation, then you know, they may just be victim of the system. They may, you know, not love what they do so much anymore. Maybe their expectations are absolutely shattered. I'm a millennial. My expectations, my whole life, my expectations have been shattered. So unfortunately for the Gen Z, I don't know if they have any expectations left, but
that's a good question. It's a great question.
Yeah, here we are.
Right.
But anyway, thank you guys. I got to run. Speaking of which, doctor work to do. But thank you so much for joining us tonight. It's been a good check-in. We might call this a fireside chat. I know this isn't much of a fire, but I do get some heat off of it. Stay safe this weekend. We'll see you Monday, where we're going to talk about MRIs, images, and how that relates to pain management. Take care. Okay.